Great. Great. I see we have Sissy and Eula. Hopefully we have you as a panelist soon. Dr. Quito, do you want to do a sound check for us before we get started?
Okay.
Good.
Hi, how are you?
Good. It sounds like it. How about a video check? Let's do here. I will turn my video on as well. Sorry, all. We're just doing a little bit of technical housekeeping before we start the session.
Okay.
Good. That works. And we need to get Dr. Mathibi as a panelist as well.
She's sent a message.
Yes. Okay. Let me see. Hold on just a second. Oh, I think I can do it. All right. Okay, there she is. Okay. Dr. Mathibi, do you want to do a sound check and video check?
Yes, good afternoon. I'm Dr. Eula Motibi.
Motibi.
TB.
Eula, Clint, it's so good to hear your voice.
And Clint.
Hi, Clint. Long time. How are you doing?
Miss you.
Miss you too.
FPD, I'm actually going to share the slides, I think, for this, and we will start with right to care, if that's fine with you all. So we just need to make sure that Amy, our moderator, hops on, and we will start at 10:10. So the other session is still finishing up, and there's a little bit of a break for people to join. So let me just make sure I can pull those slides up. Just a second. Everybody can see that?
Yes, perfect. Thanks.
Okay. I will advance them for you. And you can
Yes.
just tell me next slide. I won't be on video when I'm doing that, but it would be great if you all are definitely on video when you're talking. And then we'll do JCRC, and then we'll have time for questions and a few remarks from Clint. So I think this will. All right, it looks like the slides are fine. So I think we are all good. And Clint, you'll do these last couple of slides if that's fine with you.
Sounds good.
Okay. Well, I'm going to go on mute now and put the opening slide up because I think we'll have more folks joining.
Kelly, I had one change to that slide that said the evaluation. We ended up not using SurveyMonkey, so you could just delete that and just say, please complete evaluation.
Let me change it. I'm gonna have to stop sharing and then I'll change it and then I'll reshare.
And I'll put it in the chat again.
Hi, everybody. This is Amy. I'm here. Good morning. Good afternoon.
Oh, great, Amy.
I just can't open my video, so I've been trying to figure that out.
I think we've got to enable it for you.
Oh, you do? Okay, awesome.
Yeah, not your fault. Can maybe FPD can do that?
Hi, Eula. Hi, Sissy. Good morning.
Hi, Amy. How are you doing?
Great. Good afternoon. Actually, Eula, I've just been so impressed, and I think Ian is also on. Is that right?
Yes, he is.
Reading so much about right to care, I really didn't know that much about you all. Really impressive.
I know, so impressive.
JCRC, I do know a lot about. Eula, how do you pronounce Ian's last name, please?
Ian Zana.
Zana. Okay, I thought I would also mention him in your bio, a little bit about the beginning of right to care, because I'm sure others are also going to be curious to follow up with both of you.
I think we can see Ian there. Hi, Ian.
Just to say, I'm struggling with the settings here, but Eula is presenting on our behalf.
That's right. Yep. And Eula and Sissy, I did send you a message. I know we have a lot to cover, but I'm hoping if we can try to keep the presentations to about 7-8 minutes each, and then we'll have lots of time for discussion. And I think folks will be really interested to ask you lots of questions. We have, of course, those 7 or 8 questions already. So just a reminder.
We'll try.
I know. Well, well, do your best. You have fabulous stories to tell. So I don't want to short shrift you either.
Yeah, yeah.
FPD, I don't know if you want to pipe in the music. It looks like we do have quite a number of participants on. But I think the official start time for this is 10:10, right? So we have a few more minutes.
So you'll kick us off, Callie, and then I'll jump in and introduce Dr. Eula and Dr. Sissy, right?
Absolutely.
Awesome. Eula, how many countries are you all working in right now with Right to Care?
South Africa, Zambia, Malawi. We've got some remnants of work still to complete in Uganda. We're doing work in Tanzania, in Nigeria, in Liberia, I think we're doing some work there. And then in partnership with Code, they're in Botswana. Which one did I forget? We're working in Mozambique, not USAID, a different project, a cross-border project. Yeah, and with Equip, we previously worked in the DRC, Zimbabwe, Burundi, Ghana, yeah, and Southeast Asia, but we've exited some of those countries. Haiti as well, we were in. We transitioned to a local partner there.
And Sissy, same, you all with JCRC are still doing lots of multi-country work. Is it primarily around the lab, or is it much broader than that?
It's primarily around the laboratory.
And the research.
After we scaled and supported other programs.
Great.
Came back home, yeah.
Are we able to see our video yet?
I can see the screen.
I can see the screen, but I can't see video yet either. Video settings, let me look at that. Oh.
I see you, Amy.
You see me?
I see you.
I put lipstick on just for this session.
I think we have 2 minutes and we'll get started.
Okay. Oh, I see us now. There's Dr. Eula. Hi, Eula.
Hi, hello.
Sissy, is your camera working? Are you able to go on a video as well?
Yes, I was going to, I don't know.
There you go. Yep.
Okay. A bit dark, but that's my color.
can hear my cat meowing. I'll be right back.
Okay, Amy, Dr. Matibi, and Dr. Quito. We are delighted to welcome you to our closing plenary. I think we've saved the best for last, so thank you all for joining us to hear a really interesting session from some of Pepfar's oldest local partners, and we're really excited to hear their stories. We are starting the session at 10:10, and we will go through 10:10 Eastern time. We will go through until 11 a.m. and then have a few closing remarks from our OHA office director, Clint Kavanaugh. So without further ado, I'm going to hand it over to Amy Cunningham, our associate director from OHA, who will moderate our panel. So thank you, Amy.
Thank you so much, Callie, and welcome everyone to the last day. I think we can all agree this has been a really fabulous couple of days, and I think saving the best for last, there were lots of great things that happened, but I'm really excited about this session because it's really telling a story of local organizations who've been around for 20 years or more, and who've really been also the leaders globally in helping all of us find the way to the path to getting to epidemic control, saving lives, and also sustainable systems. So, so super excited. Maybe just a few words about me. So in case folks don't know who I am, I've just joined actually OHA. I'm going into my 4th month now, but I'm not a foreigner to USAID. I was a Foreign Service Officer with USAID in the early 2000s in Tanzania and Uganda. And then I was also an implementer of a large care and treatment program with Columbia University in Tanzania and a founding board member of a local NGO there that is doing quite well. And I think several of them are on the list today. Recently was a Pepfar coordinator in Uganda. I've done work with private sector as well. And I can tell you my passion from the beginning has been sustainability and local partners. So I was thrilled to be asked to come in and join this session, and I'm really excited to introduce our panelists. So today we have Dr. Eula Motibi, who is with Right to Care South Africa, and we have Dr. Sissi Kicho from Joint Clinical Research Center in Uganda. And I'd just like to take a moment to introduce them both before we go into the session formally. So Dr. Motibi is a medical doctor. She's an internal medicine specialist. She has 27 years of experience in interdisciplinary disciplines of clinical internal medicine and public health systems and services. She is previously the head of technical and services at Ket Impilo. I may not be pronouncing that correctly. One of the founding board members of the EQUIP Consortium, and was previously responsible for EQUIP in Burundi and DRC. And those of you who are not familiar with EQUIP, it's the very first USAID award to a local partner out of South Africa for broad technical assistance and services. She's now the executive director at Right to Care, which not-for-profit, and is the managing director of Right to Care International. And just a bit about Right to Care. They're a South African organization founded by Dr. Ian Zane in 2001 to respond to the need to create access for ARVs and HIV services broadly. They've grown to be a multi-country implementer and one of the largest NGOs globally, providing treatment with now 800,000 individuals taking ARVs under their care. They've also branched out to be a major technical assistance provider in South Africa, Zambia, Malawi, Uganda, Tanzania, Nigeria, Liberia, and other places. And they've also transitioned some programs to local partners. One of them is in Haiti. So actually, I think I will wait, Sissi, and I'll introduce you right before your presentation. I'll turn over to Dr. Eula to give us a few words about Right to Care and share a little bit of the history of the program. Over.
Thank you, Amy, for that wonderful introduction. As you say, I'm Dr. Yula Motibi, representing Right to Care, not-for-profit company this afternoon. Thank you for the invite and welcome to all. Next slide, please. So we can move the slides. Yes, so as you were saying rightfully, Amy, Right to Care was formed in 2001 by Prof. Ian Sanne and received its first grant from USAID in 2003. Now, in the interim, Prof. Sanne was self-funding as well as acquiring minor funds to continue to grow the organization. And of interest is that our first grant with USAID was termed high risk, as you know. So we are driven by innovation, trying to find solutions to HIV and TB problems, as well as infectious diseases problems. And some of the work we've done around infectious diseases has been the Ebola epidemic, as well as the cholera epidemic in Zambia. And recently, we are a major player in supporting the government of South Africa and Zambia to mitigate the impact of COVID-19. We have technical teams of doctors, pharmacists, and nurses who we have grown over the years. And all of these are motivated by our motto, which says we treat health seriously. And whatever we do, we always act with high integrity. We have built close relationships with the ministries of health, a critical enabler to delivering programs in the different countries. And we link with universities, as you see them stated there. And in time, over time, we've developed a culture of rapid movement from science, research to implementation. And as you can see, that very small high-risk grant of 175K has now expanded to a 50 million per year grant. Gradual growth and generic diversified funding has assisted us to do this. We can go on to the next slide, please. So we have lots of expertise, as you've mentioned, Amy, acquired over the years with learnings, with innovation, the health services that you can see at the top of the slides, social behavior communication, and I think recently of interest and pertinent to the situations of COVID, infection control that we find ourselves in, our pharmaceutical services division has innovated around central dispensing as well as differentiated service delivery models. So we've got these collect and go lockers, which we have placed in different countries in South Africa, Zambia, Lesotho, and these are assisting our patients to keep out of the facilities to collect their medication. Strategic information and GIS surveillance has been critical to all the work that we are doing. The slide that you're seeing there is recently we've supported the government of Zambia to develop a COVID-19 dashboard, that green lovely dashboard, which is tracking infections, tracking patients who are getting better, enabling the track and tracing of contacts, enabling the laboratory to do their work. We've also expanded into research. We have a fully fledged research unit in Zambia, and in South Africa, we are developing COVID research units. Thank you. Next slide. Yeah, so I think you've mentioned some of these, Amy. We've been around for quite some time. We are currently operating more than 10 US government contracts, both USAID, CDC, and we believe in partnering, in collaborating, right, in cooperating. So we've partnered with more than 50 global and local organizations. We've offered over 10 million people tests for HIV. Prevention, I think we are up there regarding VMMC. We're probably the foremost organization in performance of VMMC. We have employed a huge number of staff, both in South Africa, in Zambia, Malawi, with over 3,000 staff in complement. And as I said, our differentiated service delivery models supporting 800,000 patients are made up of those lockers as well as the pharmacy dispensing units. Thank you. Next slide. So looking at the factors which have enabled us as an organization to succeed in this past 20 years, as we said, we are a not-for-profit company. However, our profit is measured by the program performance, by patient outcomes, and ultimately by the impact of our work. We have a strong governance ethos. We've got an independent board of directors. The middle picture there you can see is our chairman of our board, Dr. Ali Baha. We have external independent committees. We have external and internal auditors. And to date, we've achieved 100% grant compliance when it comes to auditing. We practice function separation of duties where programs, finance, operations, right, are being managed and monitored independently. What we've also done over the years is we have developed the depth and breadth of expertise. We've got 5 layers of technical expertise, and this talks to sustainability. We've got our leadership team, obviously led by Professor Sana, who is a world-renowned HIV/TB expert and chairing the ACTG. We've got Dr. Papi Majuba, myself, and a few 4 layers of experts who are driving this program. And hopefully with time, the lower level experts will come up to take over the organization and continue the good work. Next slide, please. So what Professor Zana has done, at inception of this work is focused on, besides the clinical and technical services, a lot of focus was put on grants management, right? So Right to Care has capacitated and looked after over 75 sub-recipients in our lifetime as a UGM. But more pertinently, we've now graduated about 20 or more sub-recipients who've now become their own prime recipients of their own grants across 7 countries. And to note is our localization, as you mentioned, in Haiti, in Zambia, in Malawi, and with Equip in the DRC. So I think that is a major achievement. All of these organizations are being run by local staff, local technical capabilities supported from our headquarters in Centurion, Pretoria. Now, this Equip grant you did mention is the first African central awarded grant. We were running this work across 19 countries in Africa, in Asia, and in, where is Haiti? Again, in the Caribbean, I think. Now, also what contributed to our success was our strong focus on interventions, innovations which we knew were going to address the gaps within the system, directed towards the problems that we found ourselves in within Africa. So our first innovation was the code data system, right, which linked program performance with management interventions. And then Right e-Pharmacy, which is our flagship pharmacy intervention, which is providing DSD across the countries that I mentioned, our GIS mapping, and I think of note as well is that we were the early adopters of the Gene Expert for TB, hence reducing time to diagnosis and treatment for patients with TB. And in fact, we became the go-to group for technical assistance, viral load scale up, and we still are running viral load programs across many countries, data management, and recently with the COVID, we've had a lot of asks around models of DSD, the provision of out-of-facility care for patients. And continuously ongoing, our motto is that, to succeed, to get this HIV epidemic under control, and obviously now with the COVID, there needs to be partnerships. So we believe in strong partnerships. We believe in collaborating. We believe in cooperating, because our focus is really on the need of the public health. We need to optimize public health care wherever we are, rather than looking at optimizing right to care. Right to care is secondary. It's an enabler to all of this work. Next slide, please.
And Dr. Eula, this is Amy. I'm just wondering if we could wrap up a little bit. I don't mean to interrupt, but I want to make sure we have time for some of the questions. Thank you so much.
Okay. All right. Thanks, Amy. So learnings from working with USAID, maybe I'll just say 2 words there. And USAID has a strong focus on organizational development. And we've had a lot of support around our localization strategy in those different countries. And our agreement officers and representatives have worked really hard, right, supporting us with our innovations. And without that support, we wouldn't have been able to do what we've done. Our reality, though, is sustainability. We only have a line of sight of 5 years, right, for the funding. So maybe I'll go on to talk a little bit about our strategies for sustainability. The next slide, please. Yes. So what have we done to ensure sustainability, or as a path towards sustainability? We've done diversification of funders, as you can see there. We've also started to partner with the different ministry, where the Department of Health is contracting us to provide services on their behalf. And also our innovations are made available to any partners at minimal cost to assist us to continue the work. Next slide, please. Yeah, so I think the 5-year vision, a lot of the sustainability issues I've addressed. What we see going further is ensuring service excellence. We believe that with the excellent service, great outcomes that we provide, that the business will continue. Innovation will be great as well, to continue innovating, finding new solutions to current challenges. But most importantly is the good HR management and HR strategy. We look after our staff. We've got the retention measures in place, right? We train our staff, we mentor our staff, but obviously we pay attention to performance management, because we understand that outcomes and results are what's going to assist us to continue to do the work. I think we move on to the very last slide now. So the key learnings are: have good governance, right? And start early with good governance. We've spoken about HR, monitoring and evaluation. So plan, measure whatever you're doing, right? So that you can have revisions, you can have course corrections, making sure that you stay on course, right? And with us, what we found out is that if you align with the government processes, you align with the government strategy, right? That will stand you in good stead. And then also planning for transition, right? Speak to government, plan as you enter a program to implement. Start talking about, your transitioning over to government, your takeover to government. As we understand, their processes take some time to mature. So I have just one slide then, I think. Yes.
And actually, so, Dr. Eula, we can talk about this a little bit more. So I might ask you just to hold on this one, because I want to ask a specific question about this. Is that okay?
That's okay, Amy. Yeah, that's fine.
Thank you so much.
Then we are done. Okay.
Oh, that's,
thank you, everyone.
Thank you so much, Dr. Eula. And I've seen some questions already in the chat. Thank you very much. I think we could probably have an all-day meeting just with what you've shared. It's really powerful. And I know we want to have some time to be able to talk a little bit more and hear more about the grooming leaders in particular. So thank you so much, Dr. Eula. And I wanted to let folks know what we're going to do is Dr. Sissy will share probably about 10 minutes of history of JCRC and a little bit of their background and success, similar to what Dr. Eula did. And then we'll have time for some questions. I want to leave at least 15, 20 minutes for questions. And I have a few too to kick us off. So without further ado, Dr. Sissy Kicho is the Executive Director of Joint Clinical Research Center. She is a medical doctor and a public health specialist. Dr. Sissy is, excuse me, she has 28 years of experience. So that seems to be a magic number with these powerful panelists we have, 27, 28 years in HIV clinical care and health research. She has 194 publications in peer-reviewed journals, and she also pioneered, along with other JCRC doctors, prescribing art in sub-Saharan Africa from 1992. So that's a ways back, and has been at the forefront of scaling up HIV treatment and ART use in Uganda from 2003. She's a member of the AIDS Task Force and chair of the Uganda AIDS Clinical Care Subcommittee. She's involved in planning and writing the very first national strategic plan and ARV policy in Uganda. She's also been PI or co-PI or investigator for over 80 research projects in epidemiologic trials of HIV treatment and associated infections, and a number of intervention studies with HIV prevention and vaccines. And many of these pioneering research projects have informed policy and clinical practice, not just in Uganda, but globally. Dr. Sissy played a critical role in the development of the JCRC state-of-the-art clinical and research lab. And the labs do a number of tests, including molecular biology, HIV drug resistance, TB, pharmacokinetic studies, among others. And she's also the director of the JCRC College of American Pathologists, certified labs with the biggest menu in the entire country. She serves as executive member on a number of local and international committees. And also, little known fact perhaps, JCRC was the first USAID partner to receive funding under Pepfar for ART service delivery back in, I believe, 2002 in Uganda. And with that, I'll turn over to Dr. Sissy to hear a little bit more about the background of JCRC and how you got where you are today. Over.
Dr. Sissy,
Might need to unmute, Sissy. There you go.
Thank you, Amy, for the introduction. I'm glad to be here making a short presentation. I could take all day, but I only have about 8 minutes. Thanks for inviting me to present our experience. So the JCRC was started in 1991 by His Excellency, the President of the country, because of the HIV prevalence which we had in Uganda. That was the highest in the world at the time. So it was started as a joint venture between the Ministry of Health, the medical school at Makerere, and the Ministry of Defense. Soon after, actually, we were asked, I wasn't there in 1991, I joined in 1992 with this first study, but we were asked to find a cure for HIV, and we are still looking. So in 1992, we did the first study using AZT monotherapy. And between 1992 and 2003, we started a cost recovery program. Many patients at that time would travel to US, to Europe to get drugs. So we already had facilities to be able to monitor, and we also brought in drugs as they got available on the international market. We did in 2000 import for the first time in sub-Saharan Africa generic antiretroviral drugs from CIPLA, and we set up a network of clinics around the country. And this network model became a case study and inspired the Pepfar announcement and program in 2003. So in 2003, we were approached by USAID, and we became the first Pepfar grant recipient in the world. Next. So that is TREAT, that is what we codenamed it. From 2003 to 2010, we were the primes. And then we got a smaller grant of $19 million from 2010. International INGOs had come on board. Then we became a sub-recipient, and now we are back to prime. So we've come the whole circle, and we are back with USAID. Next. Next slide. Yeah, this is the project I was talking about. It was $69.4 million over a period of 7 years. Next. These show by December 2003, when we signed the agreement with USAID, we had a few scattered clinics around the country, and we were providing generic antiretroviral drugs at cost recovery. But what this did was increase the number of people in the country that could afford treatment at the time. Next. Next. So when we got the Pepfar grant, we started to roll out ART, and within 1 year, we were working in many districts of the country. Next. Next. But as part of the national program, we also strengthened some of the centers we had in the regions and established new ones to support the robust national program. And all these regions had laboratory capacity, which then supported the national program rollout. And it was also, there were also knowledge hubs, so we did a lot of training for other providers. And then research, which was part of our critical role, was not forgotten. So as we did program work, we have always continued to do research that actually informs the programs that we roll out. Next. Next. So these are some of the factors that led to a successful implementation. And although those factors worked then, I think they still apply even today. This was the first time we were getting USAID funding, and of course we had to learn and relearn and be trained about compliance to USAID guidelines, which we did, but as staff evolve, the learning is a continuous process. So the collaboration with EMI as one of the AORs had an intent to succeed. There was no room for failure. So USAID set aside separate grants then, and which it can do even today, to strengthen our financial systems. They gave us $69 million US, and that was, I don't know how many percent increment from what we were using as an institution. They provided a grant to support us on management issues, leadership, governance, and management. I think already Ula mentioned these are really critical for sustainability of institutions. And we were also able to recruit and pay technical staff in the program. There was ongoing technical assistance through our AOR, and there was very open communication with the clients and the community. I think as local partners, as we move forward, we cannot forget to know that we are serving our communities, and we have to get feedback from them on how we can improve what we are doing. Next slide. Next slide. So other issues included collaboration based on trust and respect. As local partners, I think we know best what is good for our countries. So it is not a top-down strategy or driving of ideas. I think it is a collaboration where we both benefit from each other. We did solve problems jointly, and USAID at that time, it was involved directly in our implementation. Next slide. Next slide. So this was the ambassador. He had come with us to one of the remotest clinics in the north of the country. Next. Next. So that was Emmy. She also went with us everywhere. Whenever we opened any clinic, we went, we marched in the streets, we mobilized people to know that there was ART and they could access it. Next. So as part of the grant, a Pepfar grant that we got, there were many initiatives that we established in the country, and of course, credit goes also to USAID for enabling us to be able to do this. We did pioneer initiative on CD4 and viral load monitoring for the national program. All those regions that you saw on the map had very high-tech laboratories. We started early infant diagnosis in 2006 because we had these labs around the country. We did provide and continue to provide HIV drug resistance testing, and we did initiate third-line treatment. Before it came to these countries, this is a new initiative in many countries, but we're already providing it over 10 years ago. We also established level 3 safety laboratories to deal with TB. Next. The partnership had to be consolidated, and one of the things was working very closely with the AORs that we had to provide technical guidance. But technical guidance was not just supervision, it was support, because jointly we either succeeded or we failed. And I think this is the same today. We succeed together or fail together, whether we are local partners or international organizations. We had very regular meetings. I already mentioned USAID was very actively participating in our activities, but now they may have too many partners. They don't have time to go everywhere. There was very transparent and open communication, and challenges were promptly identified, communicated, and jointly addressed. It is very important, I think Eula already mentioned it, to keep in touch with our ministries of health, because everything we do, whether local partners or USAID, it is on behalf of our ministries. And then again, we cannot forget the communities that we serve. They are the reason why we are here, and we need to hear from them. Next slide. So some of the discussions on the way forward, I think as we transition, we need to have very close collaboration with existing INGOs, and USAID has to facilitate this. It's not that all INGOs are very happy to go, and if the USAID does not facilitate the process properly, then they will say, oh, you see, the local partner is failing. And also the INGOs already have key field staff with high performance, and to continue to have continuity of what has been achieved, we need to retain those key staff. The local actors, including government officials and districts, now we are mostly doing district-based programs, need to be put on board early enough and always talk to them and see what their input is. There are many CBOs that have been engaged by INGOs, and I think for those that have been doing a good job, we need to maintain and sustain them. And then very importantly, as we transition into, as local partners, as primes, we have to think of our sustainability. When we were with USAID, we stopped being a prime. We got very little money as a sub-awardee, but we already had sustainability mechanisms in place. Our core work is, our niche is laboratory. We do a lot of research, and that sustained us and also kept us on the map in terms of contributing to policies that have sort of changed the practice that we do. Also succession in terms of individuals. I think you've seen Eula presenting and not Ian. My boss at the time when we did treat was Professor Mujenyi. He mentored me, and now I'm in charge, and I'm mentoring other people who will come after me, because I think I'll leave at some point. So I think as locals, we need to nurture and mentor new leaders who are going to take over when we are gone. This is the first time as an institution we get an overhead of 10% de minimis. We are very grateful to USAID, and we are saying, let us continue talking. As part of our sustainability, we need more than 10%. So in summary, that is what I had to present, and thank you very much for listening to me.
Thank you. Thank you so much, Dr. Sissi. Thank you both. This is really compelling. I picked up a few things from both of your presentations around the importance of leadership and governance. You mentioned the sustainability, sustaining your functions and your activities, regardless of whether you get USAID funding or not. And both JRC and Right to Care have diversified, have also relied on some other areas that training, research, and laboratories that really was your vision in the beginning. And I love the point about the joint USAID and IP engagement. I didn't disclose this at the beginning, but full disclosure, back when I was USAID in the early 2000s, I was the AOR for JCRC and helped get that first grant up and running. And I do appreciate that it was a lot of work for all of us. So thank you for noting, Sissy, the need to be sure that your USAID counterpart is well engaged. And the MOH engagement in community is critical. I want to just kick us off right now with one question that we left Eula with, which is around the mentoring, the growth, and the nurturing of your local staff. How do you groom leaders? Eula, we'll start with you and then go to Sissy. How do you groom leaders specifically within your organization? You might be muted, Eula, Dr. Eula. There you go. Oops. Eula, you might be muted. Let me see if I can unmute you. Oh, there you go. There you are, Dr. Eula.
Yes, thank you, Amy. So thank you for the question around how we are grooming leaders in our organization, looking at succession planning. So in my presentation, I did mention that as it is, we've got about 4 or 5 layers below the leadership. So that's where the grooming starts, that we've got different layers of senior management, middle management, and our managers are put through continuous technical training, as well as training on management, proposal development. We've got regular performance reviews, performance discussions, where our managers and junior leaders would be advocating the areas that they are needing to improve. So improvement on management ongoing. As well as that, what we have done with our staff is that they are shadowing, that's the correct word. So every leader has got an identified successor. So I would have somebody that we have identified as a takeover after me as my successor, and they would be kind of shadowing myself, obviously not with me every day, but shadowing how we are running the work and the work of the business. And
Great.
then we do, and we encourage our leaders, managers to be innovative. Everyone has got a voice in right to care, and they have to have that voice heard. So those are some of the things that we do around growing junior leaders. And as you can see in some of the slides, we go out to the field. So Ian Zanner goes out to the field and works with junior managers. So there's no task which is below any manager. I think in one of the slides, you can see him putting cements when our offices were flooded. And you can see myself in Zambia going through registers, going through patient folders, just to instill that culture of a performance and quality. Thank you.
Thank you so much, Dr. Eula. Back to you, Dr. Sissy. How are you grooming leaders to move up the chain in JCRC?
Thank you, Amy. I think most of the things that Eula mentioned apply to us and also many other local partners on the webinar today. But we have to look at leadership in different aspects. To get or to lead a team to be able to even write a good proposal to USAID that gets funded requires a certain skill. Managing teams and organizing work also requires a different skill. Then the actual knowing how to do the work also requires a different skill. The way I was mentored, I think when you came, for example, to JCRC with Rob, and you said, okay, we want to work with you, can you give us a proposal? My boss then told me, can you write this proposal? I had never written a proposal before. And so I started to write, but every week we would go and say, okay, what you've written is good. Can you add this? Can you add that? So writing the proposals, whether at USAID or CDC or even other funders, proposals that contribute to the programs that we are doing, I think is a critical element. And we do that all the time. We invite people to join us when we are writing, but I think we are not doing it now, but I think we need to put special courses or classes or practice for people, because to get any program in, you need funding. And then, of course, there is ongoing mentoring. All these INGOs have had very good people in the field, and we need to identify who are the leaders among these people. They have a lot of experience in terms of working, but sometimes if you don't identify people and give them additional coaching, they just continue to do the things they do all the time. So
Right.
I think we have a lot of people in our communities, in our countries, that have been working with INGOs that we can pick and proactively engage to get them to higher levels to take on more responsibility.
Thank you, Sissy. And I've been given a little bit more time. So I want to try to pull a couple of the questions, but we do need to wrap up in about 6 minutes. So I wanted to ask a question that one of the participants raised around sustainability and governance. What should be the correct balance between participation of the organization's senior management team on the board of directors? And then also, how long did it take you to have an independent board of directors? Can we just have a 1-minute answer from each of you? Start with you, Dr. Sissy.
How long it took us? We didn't actually have we had a board of governors even by the time USAID came to JCRC, but it was not that active. As part of the work that we were doing and USAID helping to strengthen the institution, it helped us support training, recruitment, have policies in place so that we had a functional board of governors, which then helps us to direct what we are doing, but also helps us to even get more funding besides USAID, because then they see you have structures, you have a proper and functional board of directors.
Great, thank you. And Dr. Eula?
Thank you, Amy, for the question on how long it took for Right to Care to get a board of directors. It took a few years after the inception. I think it's about 4 or 5 years. That's when the organization's funding was growing. As I mentioned, in the first few years, we were self-funding and having very minor donations to start the work. So about 4 years after the organization was set up, the board of directors was instituted. We follow the South African Companies Act, which does kind of stipulate, the non-executive directors as well as the executive directors. So we've got a majority of non-executive, non-functioning directors with about 4 executive directors on that board. I think our board has about 14 members or 13. One may have left now.
Okay, great. But clearly in both of your presentations, and folks are really interested in learning more about this on the governance side. Since we have very little time, I would like to ask you both, what are things you would have done differently on your journey? And what advice could you give local partners who are just starting out that journey? Let's just take 1 minute each, from Sissy first and then Dr. Eula.
That's a tough question. The good thing with JCRC is we had very good AORs. So for other, and these, there are also personality, issues. So I can't say I advise all local partners to have AOR. We don't choose whom you get. I think what we could have done earlier is more proactively engage USAID to give us an overhead. But I think things at that time, maybe that was not even the policy, and sometimes however much you talk, things don't happen. Because we have to think of sustainability. Sustainability, USAID and Pepfar funding will go away, but when it goes away, what happens to us?
Yes, great, thank you. Dr. Eula.
Thank you, Amy. So I think a few learnings perhaps from our side. One of the issues was setting up the governance board. So in retrospect, we are saying set it up the sooner rather than later.
Mhm.
And then the next issue is that be aware that organizations fail because not of mainly technical performance, but mainly watch after the grants, right? Make sure that your grants management is superb and without fault. Watch out for fraud and watch out for unacceptable human practices. And then with us having gone out to expand to newer countries, we've learned that when we're operating in difficult or suboptimal circumstances, we should never lose sight of what we have in South Africa as the Foreign Corrupt Practices Act. And looking back now, we say there are few experiences, right? And we learned from them.
Wonderful. And there are some great questions in the chat. I know we don't have time to go through them all together, but I would encourage Sissy and Eula, if you could take a look and just respond to a couple of them that came over the last hour. I think they will really help our participants. And I'd also really encourage the participants to reach out directly to Dr. Sissy and Dr. Eula. They have a wealth of experience, as you can see, and are very willing to help, help guide us. And really, this is a joint partnership globally. So happy to talk with both of you. And I am going to now thank you very much for participating and putting together these great presentations, which will all be shared, so everyone will get a chance to look at them in detail. And thank you very much. I'm going to hand back to Callie. Over.
Thank you, Amy.
Thank you.
Thank you so much. This has been a fantastic panel, and I really enjoyed it. So we really appreciate all the insights you've shared, and wish we could have more time to even dig into some of those discussion points that you shared. Just a few quick housekeeping items I wanted to cover, and then I'm going to hand it over to our Office Director, Clint Kavanaugh. We'd love to have your feedback on this meeting. There is a survey, and I think Catherine from ASAP is going to put it in the chat, and I think it will also be sent out to all the participants. So please look for that and use that survey to really give us some good feedback on what you enjoyed about this meeting, what you didn't, and what we can do better next time. And then secondly, I know lots of people are interested in the materials and all of the excellent presentations shared. We are working to put that together, and all of those things will be posted on the ASAP website after this meeting. The website is listed there. We also have session recordings that we will send out separately. With that, I think I'm going to turn it over to Dr. Clint Kavanaugh, our OHA Office Director, to talk about next year and also to close us out.
Thanks, Kelly, and thanks, Amy, Sissy, Eula. That session was just another reminder of how innovative and forward-leaning our partners are. Sometimes I have to remind folks that our success, ultimately, the success we achieve with the clients we serve is through our implementing partners. And this simple reminder is of such importance because our ability to set you up for success is directly linked to our agency's success. And so this meeting, that session was just another important reminder of not just the importance of ensuring that you have the tools you need to succeed as an organization, but we also leverage the innovation and forward-leaning thinking that you have as organizations. Both JCRC and Right to Care are innovators, and it's really our job to leverage that expertise. And I'm very proud of the work that Right to Care has done, not just in South Africa, but in the region. You know, as an organization, we support nearly 6 million people on treatment. A third of those are in South Africa. And they're supported by local partners. That is a reminder of not just the role that local partners can take, but the importance of building these organizations that can not just serve in the HIV response, but as we're seeing now with COVID, how can serve a broader mandate. And again, that really is something that we as an agency need to continue to remind ourselves. I want to really, really thank our capacity building and partnership branch. I think, and I've received notes from a number of you over the last 3 days of how valuable you found these discussions. And it's really a reflection of the work that our team, along with ASAP and FPD, have done to really hopefully provide a well-structured and informed meeting. They're a phenomenal team and continually drive the agency to not just meet this Pepfar challenge of shifting funding to local partners, but really ensuring that they are set up for success. I also want to thank Mark Messick and Rebecca Kershaw, our mission directors, who were on the last session. Again, the message that they delivered on how important it is to be intentional around the work we do to build local partnerships. You know, Eula and Ian are a reminder, you know, of what that can serve to do. You know, Right to Care was a small high-risk grant, and now again, one of our global leaders, not just in HIV, but really in a number of sectors in global health. We really, really take your feedback seriously. So please do fill out the evaluation. We will be distilling some of the recommendations that came out of these sessions and bringing those to the attention of our agency senior leadership. Our deputy administrator has asked for a debriefing following this meeting. Our chief of staff has asked for a meeting because they take this so seriously, to learn what our partners were saying and how we can better orchestrate our agency resources to facilitate, and again, facilitate the transition of funding to local partners, but also set them up for success. And so we will be briefing them and really conveying some of the recommendations that you've provided us over the last 3 days. We continue to have the Pepfar Oversight Board, which is chaired every 2 months and or convened every 2 months and chaired by our chief of staff. It is convened with bureau leadership that includes our Office of Acquisition Assistance, our financial office, our regional bureau leadership, global health. And this will be, again, an opportunity to highlight, again, where we've achieved success as an agency, success in supporting you as local partners, but where we need to do more. And so we'll be using that forum to talk through some of the outcomes from this meeting. I want to also encourage folks to respond to the COP21 draft guidance when it goes public. Your comments are taken seriously, and really urge you, particularly as it relates to the role of local partners, respond to that guidance. You know, we also talked about the work that we're doing on the agency HIV optimization plan, and really how we better leverage other assets within the agency to advance an HIV response. And again, it's so important because it shows that the investment we're making in Pepfar and local partners can have relevance to broader health mandates. And for me, success is not just having local partners be successful in the HIV response, but really be well-positioned for pandemic response, the work that we're doing in maternal and child health and other primary health care, malaria, et cetera. Our local partners are going to be cornerstone to the resilient response that we support in countries. We're working on a more intentional linkage between, as we've discussed, some of our G2G work, particularly at the subnational level, and the support of local partners. And there's going to be more work on that to come. At the beginning of the week, and Anjali mentioned this in her opening, that the current Pepfar SGAC strategy is coming to an end, the 2017 to 2020 strategy. They're working on the next iteration of the strategy for Pepfar, and they've made clear that local partnerships are going to be at the cornerstone of that strategy, particularly as it relates to sustainability. So it does reflect the importance of the work you're doing and the intentional role that you'll play in Pepfar in the next iteration of the response. Encourage you to work with your AORs to really tee up your successes in a succinct, data-driven summary that can feed into, particularly 2 or 3 slides that tell your successes, that can feed into the COP21 planning process. It's always great to highlight your work, and to the extent that that your work feeds into those interagency discussions, incredibly helpful. So just a plug to prioritize that over the next couple months. And again, lastly, OHA will continue to try to do what we can to provide you with information as we get it, to create a forum for information exchange, a fora for sharing programmatic adaptations and innovations. We'll be continuing the monthly calls to our implementing partners, encourage all of our local partners to attend. Again, we're trying to create fora for linking some of our local partners in one country with another, along with AORs, to better provide fora for information exchange. But again, really appreciate the feedback, and we take the feedback seriously, and hopefully we'll be able to use that as we adapt in providing you the support you need to be successful. So really want to thank everyone for their contributions over the last 3 days. I'm humbled by your work routinely. It's just really phenomenal to see, even with our current challenges of the last 8 months, your ability to innovate, to serve the clients consistently, and continue to advance our programs regardless of the challenges. So thank you again, and looking forward to hopefully seeing all of your faces in person next year, and get to enjoy some time outside the meeting to connect further. So thank you so much. Kelly, back over to you.
Thank you, Clint. I just have a few final things. As a reminder, this is the end of USAID's time at the meeting, but tomorrow we still have plenty on the agenda for our local partner and participants, the exhibit hall with lots of resources, and the poster gallery will both be open. Highly encourage everyone to take a look at all of those resources there and the posters. And as well, tomorrow there are sessions set up for you for cross-partner learning to start to create communities of practice. And then I was also reminded that we still have Doug Frankie's sessions today and tomorrow, USAID Free Zone, to ask any questions you have about compliance or regulations or audits or financial management. So please, please take advantage of that. And you will see here on this slide, I won't read it off to you, our hopes for next year's meeting. Please give us any feedback you might have in the survey. Catherine will send around the link. And again, to echo Clint's remarks, we just couldn't have done this without our local partners. So we really appreciate your time participating. I know it's difficult in the virtual setting. We really appreciate all the work that went into this meeting from our partners and our moderators and our panelists. Thank you so much, and let's keep in touch.
Thank you, everyone. Thank you so much, Sissy and Eula. I'm just
Amy.
showing my face. I wish we could see everybody's faces.
Oh, okay.
Amy, for the moderation, it was good.
The whole
Thank you.
155.
Thanks, Sissy.
Great.
Well done.
Great job.
Thanks so much, Kelly, Catherine, everyone.
Thanks,
Thanks for
Catherine.
the preparations. Yes.
Thank you. I have a little personal news too. My son is getting married this weekend. So as soon as
Woo!
I'm going on leave.
Wow,
We have one
congratulations.
son.
And
Pardon me?
good luck
We have one
on the
son.
day.
I have one son, so he's now the third of 5 kids to get married.
Wow.
Wow. That's so exciting. Congrats, Amy.
And thank you,
Congrats,
Sissy, for
Amy.
showing that picture of a younger version of me. That was a long time ago.
Very young.
The young shall grow, right?
Yes,
We
that
always
was
will.
probably almost 20 years ago. Wow.
Yeah. Thanks, Amy, and congratulations, and good luck on the day.
Thank you. And you all, best of luck and enjoy the session tomorrow. And it sounds like people are really, really keen to link up with both of you. So
Yes, thank you. The
they can
emails
do
are
so.
there. Yes, thanks.
Bye, everyone.
Bye.
Bye, Amy. Bye, Sissy. Bye, Eula.
Bye.
Bye, everyone. Thank you so much. Bye-bye.
Bye.